Okay, welcome to the Aga Khan University Bloomsbury Pakistan Joint Conversation Series. This is a series of conversations that we're having with experts in the field of various aspects of Pakistan's response to the COVID-19 crisis. The first one we did was on education. This one it will be very specifically on health. We're very lucky to have a world-renowned health expert. Future ones will cover different aspects of the consequences of COVID-19. This is probably the only one where we'll actually be talking a lot about COVID-19 itself and the health aspects. Today, it is my immense pleasure and privilege to be able to introduce our guest speaker, Dr. Zafar Mirza. Dr. Mirza has a long history in public health. He is the Director of Health at for the Eastern Mediterranean at the WHO. He is, since April 2019, the Special Advisor to the Prime Minister with a very specific remit on public health. I think probably when he took the job, he wasn't quite expecting it to be overwhelmed by COVID-19, but indeed, that is indeed what's happened. As many of you know, we should have done this live, but just to underscore how critical and important this pandemic is and how important Dr. Zafar Mirza is in managing this pandemic, he was unable to come to us at the live event because he had a critical last-minute meeting. So Dr. Mirza, first of all, thank you very much for taking the time to meet with us. It is a privilege. If I could just ask you, how is Pakistan doing and how are you doing? How is the kind of healthcare machine operating in Pakistan under these unprecedented stresses?
Well, thank you very much, Steve, and my pleasure to be with you, and my apologies for getting it delayed. Reasons you have explained. I will not waste time on this, but my apologies. Well, you have asked me that how Pakistan is faring in this. Well, COVID-19, as all of you know, it is what it is. It is in more than 210 countries, and in other words, we have 210 ways of dealing with it. And there is no cookie cutter solution to deal with it. In the absence of any vaccine or established treatment, obviously it is a scare beyond our imagination in modern times. Actually, since so-called Spanish flu in 1918, we are witnessing anything like this. And so nobody was ready for it, and nobody still know the best way to deal with it. So every country has its own realities, system, healthcare system, its governance structure, its preparation for dealing with health emergencies, so on and so forth. So Pakistan, let me tell you, giving you a little history. Pakistan, we sensed it quite early because next door in China, when it started, we knew that it will be spreading. And we started, working for it, starting bracing ourselves from 15th of January, as early as 15th of January. In other words, what I'm telling you is that since 15th of January, there has been no weekend, just to give you a taste of it. So it's a 24/7 work. So our first strategy was to hold ourselves in a position where we can stop the entry of virus in the country, because it was coming from outside. So immediately we tried to strengthen our point of entries, which were our airports, which were our land routes, which are with China especially. And we managed it extremely well. The reason and what testifies that strategy is that we coordinated it with China so well that to date, despite having now around about 70,000 cases. And despite having so many deaths, we do not have a single patient of COVID positive or a COVID positive in Pakistan, which has a travel history of China. We have 70,000 plus cases now and 1,700 deaths or plus. And to date, we do not have a single positive person in Pakistan who had a travel history of China. We were sandwiched between China and Iran also developed an epicenter in Qum, city of Qum. And whereas we could coordinate it very well with China, but we could not with Iran, and we have a long border with Iran, and a lot of our religious pilgrims go there, and they started coming back, and they carried this virus with them. So, I mean, at a macro level, what I'm telling you is the first strategy was to stop it entering, but then the second strategy was to as soon as we identify COVID positive person, we try to contain them, and we try to, stop the spread through them to others. To some extent, we were successful, but eventually, this way or that way, it is very difficult to stop the virus, so it started spreading. So as we speak today, whereas in February we had 90% positive patients in Pakistan who had a history of travel, today we have 92% of local spread. So we have long passed that stage where people were coming with virus in their bodies from outside Pakistan. Now it is spreading locally. So where we stand today is that, well, before that, let me also explain this to you, that we are passing through, and I think most developing countries are passing through a phase where very tough choices have to be made. Other day I was speaking somewhere and I said that it's like sitting in a, Airbus cockpit, which is like a policy cockpit. And you have to, deal with so many knobs and buttons that you every day you look at the data and then you push this button and release that button and increase that volume and lower this volume. And, you're surrounded by this kind of, this is, I think, I call it policy cockpit, in which we are sitting and we are trying to make the best choices, and it's not easy. The challenge is that a country which is sixth largest country in the world and which has a 25% of population living under absolute poverty, which actually means that around about this number of 25% under absolute poverty means that you cannot, even if you put a lockdown, you cannot sustain that lockdown when people are dependent on their daily wages. So when people have to earn in a day to be able to, have their dinner together in the family, you cannot lock people in homes. So from the beginning, and as the outbreak started, expanding and spreading, the choice was very hard, and the choice was between lives and the livelihoods of the people. And our Prime Minister saw it from the beginning, and he continued to say that we have to balance between the disease and the hunger. And that's where we had to make the most tough choices. Nevertheless, on 13th of March, we had only 26 cases, positive cases in Pakistan. And our Prime Minister called a National Security Committee meeting, which is the highest security forum in Pakistan, and we made some very tough decisions. We banned all large gatherings, we closed schools, we closed shops, we closed shopping malls, etc., etc. And since then, we have been sort of, sitting in every morning at 10 o'clock for a couple of hours, and we take into account the data and we make decisions. So as we speak, we in Pakistan have ramped up tremendously in the last 3 months, our capacity to deal with the challenge. When we started, we had only had 3 labs which could conduct PCR tests. Today, as I speak with you, we have, in 3 months space, we have created 100 labs all across the country. On 15th of March, we were conducting 450 tests per day. In last 24 hours, we have conducted 17,000 plus tests. So this is just to give you a feel that how much effort must have gone into this ramping up of our capacity. But in the meanwhile, we also had to continue to readjust our lockdown strategy. And gradually we opened few things, we closed few things, then reopened, then it closed. And obviously, you invite a lot of critique about this because everybody, you have advocates for one policy and opponents for the same policy, as it is happening everywhere. And some people call it that policymakers are confused. Some people say that you don't know what to do. But believe you me, we have the best data available with us, which can be available in the context of Pakistan. We have also improved tremendously our disease surveillance system all across the country. So we have what we have right now, but we are continuously readjusting ourselves. At the moment, just to give you a feel where we stand, we have a 4-strand strategy at the moment. So the first strand of that is that we continue to, and in the process, we have also opened up our lockdown. But I will explain it to you that instead of generalized lockdown, how we are trying to manage this in more specific terms. So the first strategy is to still contain the spread of the disease. And to contain spread of the disease, we have adopted basically 2 strategies. Number one, we are trying to promote and implement 26 different kinds of standard operating procedures or guidelines or protocols, whatever you call them. The basic tenet of all these guidelines is social distancing. And for public transport, for in crowded places, in shops, in shopping malls, in industry, etc., etc. And we are now trying to even put some punitive actions for the compliance of our SOPs. The second part of containment is our TTQ strategy, and TTQ strategy is tracing, testing, and quarantine. So instead of having generalized lockdowns, we are trying to, once we find a positive person with coronavirus, then we do a contact tracing of that person, and then we undertake their testing. And where we find
on that, in the UK, they say there's a major issue with that. 25,000 people doing the contact tracing, but to date, they have not been able to come close to capacity. Where is Pakistan at with its contact tracers and its capacity?
Yeah, so it always happens like this. You start and you find very few, and you have also your own capacity very limited, but gradually you also expand this. So whereas in the beginning we were finding about 5-6%, the recent most is that we are achieving about 30 to 40% of contacts tracing. And so what I was saying was that where you find more context positive, then you lock down that house or groups of house or street or group of streets or mahalla or a neighborhood. So that's what we call TTQ strategy. And as I speak with you, in Pakistan, we have more than 600 such mini to different sizes of lockdowns prevailing in Pakistan. So, in terms of containment, so one is implementation of SOPs, and the second is uh, TTQ strategy: tracing, testing, and quarantine. The second component of this is our capacity building. The second strand of our strategy is capacity building, and capacity building, especially with reference to critical care, because eventually the segment of all positive patients which goes to critical care is very small, fortunately. But then your critical care capacity must correspond with that segment. And until now, less than 50% of our critical care assets are engaged in dealing with the critical care. But the problem there is that there is a mindset in Pakistan, and I think same in many other developing countries, that people rush to big hospitals in big cities because they don't want to take a chance. So whereas you have unused critical care in many places, the big hospitals and their critical care departments are getting overwhelmed. And for that, we have, again, with great effort, we have established a national resource management system. And as we speak again, we have all hospitals across the country available on our IT platform, and their critical data is updated twice a day, and we can actually tell now today that in which city, which hospitals have how many ventilators, how many ICU beds, how many are engaged, how many are COVID dedicated ICU beds, how many vents, etc. And what we are trying to now is to actually try to distribute new patients which require critical care evenly to those places where we have still unused critical care. And that's where our focus is at the moment. Um, at the same time, this is the second strategy, and which is about capacity building and also managing our critical care assets in a more informed way, if you like. And the third strategy for us is that we are very concerned about our frontline healthcare workers. 3% of our all healthcare workers all across the country who are actually a proportion of them are frontline workers. 20% of this 3% of all positive patients are health workers, but 20% of this 3% are those frontline health workers, and rest 80% are health workers who just because of more exposure, they have also contracted the infection. So we are very, very active working to build the confidence and to provide support and protection to our frontline workers so that they feel supported and they are protected, and so that we do not have absenteeism and we do not have anxiety prevailing in our health workers. It's not easy, it's very challenging, it's uphill, especially in a resource constrained environment. It's not easy, but we are trying to manage. And the last point, that strand of our strategy, is that we are trying to coordinate through a centralized coordination system. We are a federation, we have 4 big provinces and some federal areas, and what we are trying to do is to centralize the governance and management so that, and in this we all, whole of the government approach, whole of the sector approach, Pakistan Army is working hand in hand with us, and we are trying to have a unified national approach and unified national, system. This itself was also very difficult task, because we are a devolved country in terms of healthcare. And I think it's the closest analogy is United States of America, where you have 50 plus states, and every state has its own way of doing things. And then there is a centralized Washington-based policy making, which by the time reaches to the county level, get very diffused and sometimes very confused as well. So in Pakistan, this was a rather big challenge, because devolution of power is not very old phenomena in Pakistan. And over the last couple of years, healthcare has been immensely devolved. So to bring it back to the centralized management for this health emergency was not easy. And for that, we have created a national command and operation center, where half of my life I spend in that room, where we every morning we have our chief minister sitting with us on video links, and our chief secretaries, and we are trying to not only share information but also converge on similar approach across the country. So these are the 4 strands on which we are working at the moment. And our numbers are increasing still. Over the last 7-8 days, our average deaths reported every 24 hours has gone up, and we are about 72 deaths per day on average over the last 7 days, and it is still ascending. For how long it will ascend is anybody's guess, but we have tried also to bring 4 different groups who are very good at predicting, models. We have brought them together around the table, and they try to give us one number about next 15 days at least. For the first time in last about 10 days, we are exceeding our predicted numbers in terms of deaths. Prediction modeling is not a perfect science, so there are always ups and downs in this, but we are trying to ramp up our capacity in accordance with the predictions that we have. When we will, $1 million question currently in Pakistan is that when we will achieve our peak. And our guesstimate at the moment is that towards end of this month, probably, or the beginning of July, we'll reach our peak. What happens in next 30 days is most critical for us. And we are bracing ourselves for this. So I'll stop here. I've taken a lot of time, but I wanted to give you an overview that what our strategy is, from where we started, where we are, and how we are moving ahead. Over to you.
Thank you. I think it's extremely useful to have that context. There's a number of things that come out of that. I think one of the things that I think has plagued the modelers is they based it initially on expectations from an influenza pandemic. And of course, influenza, as I understand it, the percentage of people who are asymptomatic with influenza is around 5%. And correct me if I'm wrong, but I've heard that for COVID-19, the asymptomatic infected people is more closely 30 to 35%, which means there is a huge number of asymptomatic transmitters going around in all populations. So I wonder if in Pakistan, whether you think this number is right, whether it is roughly 35% asymptomatic transmitters, which makes it a far more challenging problem to tackle. And the second question, there was a report that's just come out in the UK that British and African minority ethnic groups are disproportionately suffering both in infection rates and deaths. So I wonder, within Pakistan, where of course you have not at all a homogeneous population, but it is an Asian population, whether you are seeing different infection rates or mortality rates based on any ethnic categorization or province or region, or whether we can correlate this simply with pre-existing conditions and poverty levels.
Well, let me begin by saying this, that the kind of the character of the outbreak as it has unfolded in Pakistan, and not just in Pakistan, but also in South Asia at large, in India, and in Bangladesh, it is very different than what you have witnessed in Western Europe and United States. Ours is slow and low, which is a blessing in a way that the way numbers wrapped up in many European countries, especially in Italy, Spain, and France, we have not witnessed that kind of scale of cases and deaths. That is now why this happens is again very speculative. There may be 6-7 factors and their interplay, which has caused this kind of outbreak in this part of the world as compared to in European and American geographies. Now, having said this, we talking about asymptomatic, by definition, since they are asymptomatic, you cannot reach to all of them, and you can never know the exact number. But we obviously are very cognizant of this, and the numbers are increasing of asymptomatic people not having any sign symptom when tested. If they are positive, this means that and such numbers are increasing of asymptom. But what people often forget is that and that's where, you know, a little bit of understanding of the disease itself is becomes very useful, because by definition, asymptomatic patient might be carrying virus in their bodies, but since they are asymptomatic and the basic vehicle of spreading virus is coughing and sneezing, so since they're asymptomatic, the spread of virus is not that huge from asymptom, unless you are super spreader. You don't have that kind of spread. Although now there is evidence that even talking, you can also spread. But in the nutshell, what I can answer your question is that yes, asymptomatic and but I refrain from putting a number to it. We don't know. But what I can tell you is that our positivity today was 24%. 24% of those 17,000, for example, which we tested in the last 24 hours, 24% of them were positive. Many of them were not having symptoms. Many of them also fully recover. And our recovery rate is also around about 30% at the moment. So, to be honest, we are less worried about the 80 to 85% of the positives, because they only have mild to moderate disease and they fully recover. The segment which goes in, gets hospitalized, and the subset of that which goes into critical care, and the subset of that which goes on oxygen, and the subset of that which goes on to ventilators, this number becomes very small actually in the larger scheme of things. And yet your critical care capacity needs to correspond with that. So we have been focusing on that part as much as we could. And critical care by nature is such that you can't ramp it up even in few months, because especially when you have to procure things from outside the country, and when there is a rush, global rush to get ventilators and ICU equipments and this and that. So we are struggling on that side. But what I can tell you is that less than 50% of our IC or high dependency unit assets are engaged, less than 50%. But when, as I was earlier saying, if you go to a big hospital in a big city, in our provincial capital, you can already feel that the system is getting overwhelmed. And that is because of that, what I earlier explained to you.
Yes.
As far as the homogeneity of the population is concerned, we do not see much problem there in terms of different rates of infection in different communities at the moment.
Okay, thank you. Can I change tactic a little bit? One of the big issues, I think, around the world is the messaging from the government. So the WHO is giving its best advice. Governments give their best advice. Sometimes governments give mixed messages. I think in the UK right now, latest polls suggest that the population's trust in the government has dropped sharply as a consequence of some of this mixed messaging. I know that you are yourself responsible for a lot of this messaging. How would you rate the Pakistan government's messaging? Is it clear? Do Pakistani people know what they're supposed to do? And to what extent do you think they are prepared to comply with that messaging?
Yes, you are very right. And if this can happen in societies where you have more than 95% of educated people, if this can happen there, you can well imagine what will be happening in countries where literacy is very low, urban-rural divide is very high, and the beliefs, health systems are very diverse. So messaging is one thing, and reception of those messages is another thing. So even if when you are very confident that you are giving a uniform messages across the country, you can never be sure in these settings that your uniform message will be received uniformly also by people. So we recently had a Gallup survey in Pakistan, and about between 35 to 40% of respondents had very strange views about COVID-19. And a sizable proportion of them felt that actually this is all made up. There is no COVID-19. It's just that government and maybe some imperial forces are trying to, make this such a big thing. After all, we have so many other diseases, and why we are overreacting to this, and why we are making such big thing out of it. But on the other hand, as you move to especially urban areas and especially in big cities, obviously the consciousness is very high, and the compliance to the social distancing policy is also quite impressive. Google releases country by country data about the mobility, and our data is actually quite impressive in terms of when we initiated our lockdowns, how it impacted mobility, and it's not bad. But we are as I told you, we have a dual challenge of opening up economy and at the same time trying to minimize the spread. And this is asking for too much in an environment where you are also encouraging people to move for their livelihoods, and at the same time you want to contain the disease. So that's where that's the heart of our challenge.
I've seen some rather alarming videos from Rawalpindi, Islamabad, where people are queuing up to go into shops, and the markings are on the ground, so it's clear how far they're meant to stand apart, and like they're absolutely ignoring that. So where does responsibility lie with this? How do you actually, you've talked about the sanctions, but I think nobody wants a kind of draconian crackdown on individuals, but how do you move from the place you want people to be to where they go?
So since yesterday, or day before yesterday, when we had our National Coordination Committee, which is chaired by our Prime Minister, we have decided that especially ensuring compliance of the SOPs, we have developed a strategy and shortlisted 3 areas where we want to ensure compliance. And I'll come to the strategy part later. These 3 areas, one of them is shops, the other is public transport, and the third one is industry. And why we have, and having said this, we have a negative list which we are maintaining our, lockdown. These are big gatherings. These are schools and universities which are still closed. These are, some sectors of industry, sports, tournaments, etc., etc. So they are still closed. So it's not the general understanding about easing lockdown is sometimes misunderstood about Pakistan as if we have opened everything. So a large part is still closed, but a large part is also eased out.
Mm.
So now why we have shortlisted these three areas is precisely from what you were saying, that you don't want to be draconian on individuals. But these three areas, if you talk about shops, somebody owns shop. If you talk about industry, somebody is running that industry in terms of ownership. And when you talk about domestic travel, it is either on roads or on trains or on airplanes. So all these are relatively formal sectors, and somebody is responsible. So we are making those people responsible who own these things to ensure compliance, instead of asking individuals that why you are not wearing masks. We will ask the shopkeepers that why you are entertaining people who are not wearing masks, and why you are not keeping the social distancing. And if we give them 2-3 warnings, and after that we are going to close them.
Okay.
We are going to close them and making them as examples and actually projecting them on national media. That if owners of shops, industry, and transport, if they will not ensure compliance, then they will have to lose their businesses. So this is the strategy that we are adopting now. Having said this, also we have two other very important strands of strategy. One is that we have made mandatory the mask wearing. If people are in crowded places, they have to wear masks. They have to wear masks in shops. They have to wear masks in mosques. They have to wear masks in transport of all kinds, and they have to wear masks in factories or industry. So, and the second, which we are focusing now, which we have started focusing on now, is people in old age. Because more than 80% of our deaths until now are people who belong to age bracket above 60. And about 82% of them are those who have comorbidities. So we are focusing on these high-risk groups, and we have developed special guidelines for old people, for geriatric population. So the strategy is that try to fix the fountain head rather than the flow of the water, because once you focus on those who have more influence and their businesses will be dependent on compliance of the SOPs, there you have more chance of compliance rather than start finding individuals who even if they know that there is a risk, still compelled by their day-to-day livelihood needs, have to come out. So instead of targeting them, we are targeting relatively more responsible formal sector people whom we are going to be very hard on, and we will make them accountable.
Thank you. I appreciate you do not have masses of time for me, so I'd like to ask you just one last question. I don't want to walk away without asking you to do a little bit of comparing. You said there are 210 strategies, 210 different ways of dealing with this. Now, some obviously seem to be doing better than others. South Korea seems to be doing okay. The UK, the United States, decidedly not okay. You've already indicated some of the unique characteristics of Pakistan that are a particular challenge that wouldn't necessarily apply in Europe or in North America. But I wonder if I could get you to comment, at what level is it possible to actually have a global coordination for this? I know we've talked about G7, G20, G8 coordination. But is that realistic? Is that possible? And I wonder if you could just tell me, very briefly, because I appreciate your time is precious. What are the kind of hallmarks of countries that have done this particularly well or particularly badly? So what do we need to be looking for in our own countries? What do we need to be asking our governments to be doing that might improve our chances of getting out of this with a lower death rate?
Well, you see, it sounds very good, but practically it is very difficult because of the very diverse economies, sociologies, and cultures, and also the capacities of the health systems. So, I mean, if you go by all the guidelines and all the SOPs that have come from World Health Organization, if WHO has a membership of 194 countries. So if every country follows that, we will have less of them, and there will be a better coordination. But the thing is that economic resilience, resilience of national economies play a very major role. As I've been explaining to you, our compulsions to open economy are very different than what Germany would have or Sweden would have. So if you are resilient enough to take long-term lockups, you can do that. But what we are seeing now is that even America is also opening, and Europe is also opening their economy because it is not sustainable. So coordination, experience sharing, good practices is all very good, but its application on ground is very challenging. But having said this, let me also say, as my last thought, is that I think the world will obviously see through itself this global epidemic. I think the real coordination will come as the world come out of COVID-19. How the debt relief will be ensured in order for developing countries to reset their national systems, including healthcare system. And I personally feel, and I'm actually planning to write as a health minister to the Director General of WHO, that we should actually start thinking the future of healthcare in the world. Because one thing which has been established by this experience is that there is no concept of national economy and national security without health security. And unless you start investing in health and security, and indirect way of investing in health security is also start investing in human capital and develop your health systems and make them resilient enough that they can bounce back. They can respond well and they can bounce back in the recovery phase. And I think more than ever before, there has never been actually in modern history, there has never been such high level and such concentrated political attention to a health issue as we have now today. The question is that how we come out of it and what we learn from it, and how we leverage the germ of opportunity which lies in the heart of this challenge, and how we reset our national priorities to start building our healthcare systems for the future. Because if we don't do this, we will be offering ourselves for new such catastrophe in near future, and who knows when. So I think the real challenge of coordination and solidarity and the empathizing with each other as a shared agenda would be investing in our healthcare systems for the future by making emergency preparedness as integral component of that new healthcare systems.
Mm.
You don't have to start from the scratch every time when you have this kind of challenge in front of you. The other kind of solidarity which is needed and coordination which is needed is that as the vaccine become available, as the treatments become available for COVID-19, they are equally distributed and they are equitably accessible to the populations all across the world. The one thing which we should learn from it is that any uncovered or unprotected population anywhere in the world is a threat to the rest of the world. So the negative externality, as we call it, of public health must now derive and drive the future planning. So the future of healthcare, if there was any time in human history to really focus on this globally, is now. And as we come out of it, there will be a window of opportunity where if we do this, we will do well, and it will be a good it will be a good sustainable response to this. But why I say window of opportunity, because it's a human nature that once the emergency is over, you go back to your usual ways of doing things, and your allocative efficiencies and competing priorities take over, and what looks more urgent, even if it is not important, becomes a bigger priority than what is urgent and important. Over to you.
Thank you very much, Dr. Mirza. I would like to thank you. This has been tremendously interesting and educational for me. I've learned a great deal. I'm sure that our audiences of Bloomsbury, Pakistan and Aga Khan University will greatly appreciate that you've taken the time here to clarify and expand on some aspects of government policy and the wider health consequences. And to your final point, I think those of us who have been beneficiaries of National Health Service in Europe will welcome very much a kind of expansion of that and building that into the level of basic human rights for everyone, not simply for those of us lucky enough to be in the European Union.
Steve, if you allow me, before you conclude,
Certainly,
let
yes.
me also add another very important dimension which is not being talked a lot, is that whereas we all talk about the economic fallout and we talk about social fallout, political fallout, we are not talking still about the health fallout. The communicable diseases and their spread in last 3 months, other than COVID-19 and unattended routine healthcare of non-communicable diseases, there is so much hidden suffering because of these lockdowns and closing of your OPDs and all that. There is, I think, in coming months we will realize that what it has done to the burden of disease in our societies, because we have been so much focused on COVID-19. And in the meanwhile, the immunization rates have gone down. In our case, the polio has remained unattended for 3 months, and tuberculosis incidence has gone up, hepatitis C has gone up, and who knows what else. We will only know once we start gathering the data about this as we come out of it. So the challenge will be very huge. Another reason that in the future of healthcare has to factor in the health conditions and what I should say, public health fallout other than COVID-19 in this time.
I couldn't agree more. I think we're hearing from my colleagues in Karachi at Aga Khan University Hospital that they now have the capacity to deal with non-COVID patients. But of course, people are frightened to go to the hospitals unless they are going for COVID-19. So they're leaving cancer in particular not getting treated, other kind of chronic situations not being treated. So let me stop here because I know that you have a great many things to do. Please do continue this work. We need people like you. And I know you do interact with the frontline healthcare deliverers. So please, on my behalf, let them know that we're very grateful for their service and their sacrifice. I think they are very much working on all our behalves everywhere. So Dr. Mirza, without further ado, I will thank you very much.